very much. First of all, I would like to thank the organizers for this very, very kind invitation. Very happy to be in Peru, Lima again. And second point that you mentioned, I'm very sorry to present like this because in jeans and shirt only because my suitcase did not arrive with me yesterday. I hope to have it today.
What airline? So
it was a nightmare because
what airline?
It was Avianca from Punta Cana. And yes, because I flew from Paris to Punta Cana and then to Lima. I hope to get it today, not sure, and I'm very sorry for this. Does not work. The nightmare continues. Okay, thank you very much. Thank you again. So, I will speak about basic, like rising. My conflicts of interest are on this slide, and I would like to just to remind you, even if you know very well, but to remind you what is the definition of fluid responsiveness. To me, it is defined as the capacity of the heart to significantly increase its stroke volume or its cardiac output in response to a volume challenge. And I want to refer very briefly to the Frank-Starling curve, stroke volume on the y-axis, and ventricular period on the x-axis. As you know, this curve is curvilinear, not linear. This is a Frank-Starling relationship, meaning that if you increase period while the ventricle is working on the steep part of the Frank-Starling curve, stroke volume increases, and this condition is called period responsiveness. If you increase period while the ventricle is operating on the flat part of the Frank-Starling curve, there is no increase in stroke volume, and this condition is called period unresponsiveness. So fluid infusion will increase stroke volume of the left ventricle, of course, only if both ventricles are period responsive. So fluid responsiveness is equivalent to biventricular period responsiveness. And there are some studies looking at the rate of response to fluids in patients. This is a whole study we did in the past, systematic review of the literature, and we observed that around 400 patients with shock, only 52% responded. In other terms, 48% of patients did not increase their cardiac output in response to a challenge. So, in addition to this, if we remember the physiology, we have also the diastolic function of the ventricle with, again, the preload on the x-axis and the left ventricular endosteric pressure on the y-axis. So, if you increase preload while the ventricle is on the flat part of the Frank-Starling curve, you also observe an increase in the left ventricular endosteric pressure, a huge increase. So giving fluids to patients who are not period responsive is very dangerous. Not only you do not increase cardiac output, but also you increase the pressures, the feeding pressures, with a higher risk of pulmonary edema, of course. In addition, if you give fluid, you can create some hemodilation, you can decrease hemoglobin concentration. So in fluid non-responders, by definition, cardiac output does not increase, so oxygen delivery can decrease. Only in fluid responders, fluid infusion can induce an increase in oxygen delivery. And this is proven in this paper we did in our institution with the Lemone years ago. So we have to think before giving fluids to patients. In addition, we know that this can be associated with higher mortality. The SOAP study by Jean Paul and co-workers showing that the positive cumulative fluid balance was an independent factor associated with mortality. So, gathering fluid is good, but could be also harmful if you give too much fluid. And this is why the international societies and recommendations now recommend to use dynamic variables instead of static variables to predict fluid responsiveness before giving too much fluids. But I told you that the Frank-Starling curve is very important. Yes, but there is no one single Frank-Starling curve. There is a family of curves from a normal heart to a failing heart. And therefore, if you measure preload by whatever you want, CVP, wedge pressure, volumes, area, BNP, etc., the same value of this marker of preload can be associated with preload responsiveness or preload unresponsiveness. This is why we cannot use static markers of preload to predict fluid responsiveness. Assessing preload is not assessing preload responsiveness, and static measures of preload cannot reliably predict fluid responsiveness. And this was demonstrated by many studies. This is a meta-analysis by Paul Merrick, looking at the predictive value of CVP, central venous pressure, to predict fluid responsiveness in critical patients. Many patients were included in this meta-analysis, many studies, 43 studies, and the summary area under the ROC curve for the prediction of fluid responsiveness using CVP is only 0.56, which is exactly like fluid coil. So, this is why we need dynamic indices, dynamic parameters. And what is a dynamic parameter? This is something which can quantify the slope of the Frank-Starling curve the time you decide to give a treatment to your patient. And we have two categories of dynamic indices: heart-lung interaction indices and passive aggressive test. So heart-lung interaction indices is not my talk today, this morning, but you know that we can use pulse pressure variation, spot volume variation, but you know there are many limitations to use all these indices, many limitations which can be encountered in the ICU. Arrhythmias, low vital volume, spontaneous breathing activity, etc. There are other tests like, there are other tests like passive aggressing, which is doable, feasible in many patients, ventilated patients as well as non-ventilated patients. The idea behind is that if you perform a passive aggressing and if cardiac output increases, probably the patient is preload responsive. If cardiac output does not respond to passive aggressing, probably the patient is not preload responsive. This is the idea behind. And now it is recommended by the Surviving Sepsis campaign. I'm very happy with this field. To perform passive aggressing, and I'm very, very happy with this. You know this maneuver. It consists in moving the bed of the patient. The bed of the patient, not the patient, but the bed of the patient from the semi-recumbent position, which is a natural position in the ICU, semi-recumbent, to a position where now the head and the trunk are horizontal and the legs elevated at 45 degrees. And this can transfer some blood, venous blood, from the legs compartment, from the abdominal compartment towards the intrathoracic compartment. And this can increase preload. This can increase feeding pressure. This is a study we did years ago now with Thierry Boulin. We measured right atrial pressure. And we measured pulmonary artery occlusion pressure using a Swan-Ganz catheter. Before, during, and after passive aggressing, PLR. And we observed in almost all patients an increase in the right atrial pressure and in the POP, suggesting that PLR can increase preload of the left and of the right ventricle. So, in fact, it mimics free challenge. It mimics free challenge. But, fortunately for me, unlike free challenge, no fluid is infused and the effects are reversible. But of course we have to check, we have to assess the hemodynamic response to passive leg raising to predict the hemodynamic response to volume infusion. So what are the advantages of PLR? First, it provides a good prediction of fluid responsiveness. It's not just a statement, it's not just a sentence, it was proven by many studies. This is a meta-analysis we published years ago with Paul Merrick and Xavier Monet. We included 21 clinical studies, almost 1,000 patients. It's not negligible. 15 or almost 20 years ago, when I presented PLR in congresses, people said, you have only 20 patients. This is nothing. It is nothing. So you have to prove more. Okay, now we have, in this meta-analysis, almost 1,000 patients. And some papers were published later, and probably if we redo this, we have more than 1,000, of course. And what we found that the changes in cardiac output during PLR were well predictive of fluid responsiveness, with an area under the row curve now of 0.95. It is totally different from CVP, for example. And the threshold value was 10%. We are fortunate to find 10% because 10% is more. It is easy to remember. Second advantage, unlike free challenge, the effects are rapidly reversible. Look at this paper I showed already, and after PLR, a few seconds after passive leg raising, all the pressures went down and returned to baseline. So there is no risk of pulmonary edema. Third advantage, PLR well predicts fluid responsiveness in situations where pulse pressure variation fails to do it. For example, in case of spontaneous breathing activity. We performed a study years ago with Xavier Monet and others in my institution. We used esophageal Doppler to assess the effects of passive leg raising, and we included only patients with spontaneous breathing activity. And what we found that PPV cannot well predict fluid responsiveness in this population. Look at the area under the rock curve, which is close to 0.50. But the changes in cardiac output during PLR well predicted fluid responsiveness, and the area is totally under the rock curve is totally different here. Another situation, which is very frequent in the ICU, is patients ventilated with low tidal volume. You know, when I say low, it is around 6 ml per kilogram. But now it is normal tidal volume. It's not low. It's normal tidal volume. So if I submitted a paper using the term low tidal volume, and the editor said, no, it's not low, it's normal. It was just 6 ml, so I changed it to tidal. And also lung compliance. Lung compliance is the situation where, like in ARDS, PPV does not well work. This is a study we did, again in our unit, and we compared the effects of cardiac output PLR and pulse pressure variation in patients with low compliance of the respiratory system, less than 30 ml per centimeter of water. And there is a big difference in the areas of the road curves. And another advantage is that PLR was shown to be associated with a better outcome versus CVP in a single center RCT, including septic patients. This is a study performed in France, in Lyon, and it was a small study. Only 60 patients were randomized. In red, the control group using CVP, and in blue, a group which is called the preload dependence group, using either PPV, 5% of patients, and passive leg raising, 95% of patients. And it was a small study, the outcome was not different, but look at the p-value, 0.07. It was not the primary endpoint. I think that if they had more patients, probably it would be positive. But interestingly, the lactate level decreased more and earlier in the PLR. So probably there are some advantages to use PLR versus CBP. There are some constraints to use passive light grazing, of course. Sympathetic stimulation must be avoided during the procedure. Again, move the bed, not the patient, and monitor the heart rate. If the heart rate does not increase, probably the sympathetic stimulation is not so high, and you can trust the numbers. If heart rate increases during passive grazing, you have to be very cautious about the interpretation of PLR. A second constraint is PLR should not start from a horizontal patient's position, but from a semi-recumbent position. And this is what we studied in the past years ago now, almost 10 years ago, more than 10 years ago, with Julien Jagot and Xavier Monet. We compare the two positions, the starting position with a semi-recumbent position and horizontal position. And in fact, we included 35 patients, all responders. We included only responders to fluid. And look, when we use a semi-recumbent position as a starting position, all patients were well classified as responders. When we use a starting position, 20 patients were correctly classified and 15 were not correctly classified. So again, start from the semi-recumbent position. I will skip this. Sorry. Another constraint, which is very important, is that the hemodynamic response to PLR should not be monitored with arterial pressure, but with cardiac output measurements. It's a pity. I would have preferred the opposite, because arterial pressure is easier to measure, of course. And in this meta-analysis I showed before, cardiac output works very well to predict, but the changes in arterial pressure, burst pressure or systolic arterial pressure, did not predict very well. The area under the raw curve is 0.77. For some people it's not so bad. For me it's bad. And the special value was 12%. So it is better to rely on changes in cardiac output. And also, because the effects are very transient, a real-time cardiac output monitor should be used. Not thermodilation, for example, but a real-time cardiac output monitor. And this is very, very, very important. And you can use whatever you want. Esophageal Doppler, ESCOM, PICO, flow track, Vigilio, echocardiography, bioreactance, whatever you want. And it works. All the papers show that it works. And more recently, we tried with Alexandra Berton and Xavier Monet, we tried to use the perfusion index using a non-invasive device. You know, this is an index which is derived from the plethysmographic signal, pulse oximeter, PI, perfusion index. And we compared to cardiac output. And interestingly, the increase in perfusion index during PLR by more than 9% well predicted the increase in cardiac index during PLR by more than 10% with a good sensitivity and specificity. In other words, we can use this kind of non-invasive devices just to look at the changes during PLR to predict the changes of cardiac output. And also some people, it's not my team, but it is a team from France, use a capillary refill time, you know, and look at the variation of capillary refill time during PLR. So it is a non-invasive sign, of course, and the variation predicted well through responsiveness during PLR compared to baseline capillary refill time, for example. So it is interesting because this is non-invasive. This needs to be confirmed, of course. There is another limit, which is in case of intra-abdominal hypertension, PLR passive grazing may be unreliable. And this is a very recent study we performed in our unit, published in CCM some weeks ago, in August, I think. We looked at patients with no intra-abdominal hypertension and patients with intra-abdominal hypertension. In the group of patients with no intra-abdominal hypertension, PLR worked very well, and the changes in cardiac output were well predicted through responsiveness, while in patients with intra-abdominal hypertension, it did not work very well, and the area under the rubber is not good, essentially due to false negative cases, meaning that you have no increase in cardiac output during PLR, but you have an increase in cardiac output during food administration. So my conclusion, we have predictors of full responsiveness, pulse pressure reduction or SVV, but which are not feasible or interpretable in many conditions, but we have the response of real-time cardiac output to PLR, which is good, and all these markers are helpful to select the best fluid strategy by identifying patients eligible for fluid infusion and by avoiding to fluid overload patients who would be fluid unresponsive. And the knowledge of their conditions of applicability and the knowledge of their limitation is fundamental, PLR being the most feasible and interpretable test at the bedside. Muchas gracias.
Bien, vamos a aprovechar acá si tienen algunas preguntas para el doctor en este momento. Que va a dictar su siguiente conferencia. Any question?
Luis, un gusto tenerte nuevamente acá. Primero, para tratar de resaltar lo que has mencionado, sobre lo que es la variabilidad de presión de pulso y la variabilidad de volumen sistólico. Lo que está pasando actualmente es que nos llegan monitores que nos dan ya automáticamente la variabilidad de presión de pulso y la variabilidad de volumen sistólico. Y si no tenemos el concepto claro que hay que cumplir criterios para que esto sea válido, muchas veces se está administrando fluidos con los pacientes con estos índices dinámicos y sin embargo los pacientes o están en respiración espontánea, o están con arritmias, o están con una compliance pulmonar muy restringida. Entonces, creo que eso que he mencionado hay que rescatarlo, que uno no puede usar estos índices si primero no ha hecho un checklist para ver que cumplan los criterios. Y lo otro, en lo que mencionaste de la elevación pasiva de miembros inferiores, pregunto, en el contexto de una hipertensión intraabdominal, yo necesito saber si mi paciente respondió con volumen. Tengo el contexto clínico en donde clínicamente veo de que no hay poco riesgo de edema pulmonar o no existe edema pulmonar. Pero tengo el otro paciente que sí tiene probablemente riesgo de congestión pulmonar. ¿Qué estrategia usas cuando te encuentras en este contexto de hipertensión intraabdominal que te inhabilita la elevación pasiva de miembros inferiores? Gracias.
Thank you for the question. It is a very difficult question to answer because we have no answer. I have no answer, to be honest, because you cannot rely on CVP. In case of intra-abdominal pressure, CVP is not reliable because, in fact, it is influenced. CVP is influenced by the effects of intra-abdominal pressure. So you can have, for example, 16 is not 16. The transmol should be calculated, and it's very complicated. And even if you have the transmol CVP, it's not a good index of fluid responsiveness. First, PPV is not reliable also, except if the patient is totally sedated or under controlled mechanical ventilation. But we know that the threshold values for PPV are higher than in the normal case. So maybe 20% is the threshold value in case of intra-abdominal hypertension. So we have to be very careful when interpreting PPV, and also, as I showed, in case of intra-abdominal hypertension, you can rely on passive light So what to do? I have no answer. I would do like all those to look at the response because I have no way to be sure that the patient will respond or not to treatment administration. So it is a good point, and I have no answer for this. Maybe next year I will see if I come back. I will find a solution. But today I have no answer.
Thank you. ¿En español o en inglés? English is better. Or?
English is better.
Thank you for the audience. Una pregunta sobre la metodología del último trabajo en que compara pacientes con aumento de la presión intraabdominal versus sin aumento de la presión intraabdominal. Para aplicar esto al lado de la cama del enfermo, ¿cómo defines hipertensión intraabdominal en ese estudio, en la metodología? ¿Por un nivel de presión en la medición en la vejiga urinaria?
Yes, we use the vesical bladder pressure, as a reflection of abdominal pressure, and we define, but maybe we were wrong, but we defined intra-abdominal hypertension as a bladder pressure higher than 60. But I think we look at different threshold values and it does change. You cannot rely on PLI in this case. I have a question for Phil.
Pregunta para el doctor Delinger, por favor, aprovechando de que...
How are you? Good to see you.
Me too. You know, I am a defender of the combination of vasopressors and epinephrine plus fluids, even at the beginning. I'm very surprised by the last study. You showed the trial waiting for 3 hours before randomization. I think it is too late, and patient will die for hypertension before. Nevertheless, in my practice, I rely on the diastolic arterial pressure to decide the time to give vasopressors. What do you think about this?
Yeah, we have an algorithm, a flow diagram that's coming out in Journal of Critical Care, and it's expert opinion, but we recommend that vasopressors be started immediately if the diastolic blood pressure is 50 or lower. That regardless of what the mean arterial pressure is, that warrants initial vasopressor therapy. And you know, I'm surprised you haven't written a review article on diastolic pressure and its importance in resuscitation and septic shock, because it makes sense. Remember that often you have a left ventricle that's suffering from depression, and the left ventricle only gets blood and oxygen during diastole. So I think diastolic blood pressure has been long ignored. I'm talking about the hour 1 bundle at 9:50, but the hour 1 bundle, one of the major changes is you don't wait for the initial fluid resuscitation to see if you need to start vasopressors, that you want the MAP up to your target within the first hour. And you may be saying that it needs to be up immediately, but pretty soon. I also will show an editorial that I wrote about an article published in Critical Care Medicine that looked at prior data that had been gathered and showed an association between the earlier you started norepinephrine, the better the outcome. Now, whether that identified better bedside clinicians that were taking care of the patient, or whether it identified patients that were likely to get less fluids, or whether it identified patients that got their tissue perfusion pressure up early. But that was a long-winded, I agree with you.
Profesor Deringer, nos ha mencionado que hay un Profesor Deringer, nos ha mencionado que hay un estudio en curso para comparar más vasopresores, menos fluidos versus más fluidos, menos vasopresores, en este caso no la adrenalina. Hay múltiples publicaciones, claro que son estudios observacionales, pero incluso de gran escala. En alguno ha participado usted con más de 2.800 pacientes, publicados en el Critical Care Medicine en 2014, en donde nos muestra que en ese grupo de pacientes que se usaban vasopresores tempranamente, entre la primera y segunda hora, hubo menor necesidad de fluidos y esto se asoció a menor mortalidad. Teniendo todo este tipo de información, sé que no son estudios, ensayos clínicos multicéntricos, pero son varios estudios observacionales que hablan de que los restrictivos de fluidos van mejor. ¿No sería, disculpe la palabra, antiético hacer este estudio que está en marcha comparando a un grupo con más fluidos y menos vasopresores? Gracias.
The New York Times reported that there are academic physicians that thought this was unethical. And this was reviewed by the NIH and an independent IRB, and they were able to defend it and keep the trial going. If I was the primary investigator of that study, I would be most concerned about a big treatment benefit favoring the early vasopressor group. But we've been fooled before. and we get results that we don't think we're going to get, and then we go back and try to figure out why we got the results we got and learn from it. So I think we'll learn a lot from this trial. It would have been nice to have patients randomized to 3 arms, a more intermediate arm, but very good point. Did you have anything you wanted to say about the fluids?
No. Nothing more.
Muy bien, muchas gracias.